Okay.
Okay, so today we'll be having our prime or obstetric session. So we are delighted to have our two honorable lecturers, Dr. Azha and Prof. Hamiza. So for the first session, we'll be having Dr. Azha to deliver, to discuss the topics on hypertension and diabetes in pregnancy. And then we have a break and continue with the session with Prof. Hamiza, anemia in pregnancy and multiple pregnancy. Okay, so before we begin, let's start our session with Al-Fatiha. Okay, next I'll invite Farisham to recite the dua.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اللهم اقرأ علينا حكمتك وانشر علينا من خزائن رحمتك يا أرحم الراحمين رب اشرح لنا صدورنا ويسر لنا أمورنا واحلل عقدة من ألسنتنا يفقهوا أقوالنا اللهم ارزقنا فهم المؤمنين وحفظ المرسلين وإلهام الملائكة المقربين في عافية يا أرحم الراحمين رب زدنا علما وارزقنا فهما صلى الله على سيدنا محمد وعلى آله وصحبه وسلم الحمد لله رب العالمين.
Okay, so then I'll pass the floor to Dr. Azhar. Okay.
Okay, insyaAllah. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah rabbil alamin. Wassalatu wassalamu ala asyrafil anbiya wal mursalin wa ala alihi wa ashabi ajma'in. Alhamdulillah. Thank Allah for giving us the opportunity to meet once again after such a long time. I am honestly missing you guys. I can still remember your smiling faces and your cheerful joining the ward round, conducting deliveries. Alhamdulillah. So today I will discuss a couple of topics which are highly likely will be in your exam, highly likely you will meet throughout your career as a doctor, as a houseman, as a clinic doctor, okay? And some of you may even become obstetrician, inshallah. Okay, I will pray some of you will become obstetrician and join us in the fraternity of UIA lecturers, inshallah. So, okay, ONG family, yeah. Okay, so I will start my presentation with hypertensive disease in pregnancy first, and then followed by the diabetes. Okay, I'm sorry that I haven't prepared a fancy slide or interactive quiz or anything like that. So it could be boring, but that's life. Okay, do you agree? So it's up to you whether you want to learn or you want to go away. I don't mind. You can turn on your camera if you want, but if you don't want, I don't mind. Don't worry. Okay. Can you see my slide? I think it's a hypertensive disease in pregnancy first, yeah? Inshallah. Okay, excellent. So, as a lecturer, it is my duty to give you up-to-date knowledge as well, inshallah. Yeah. So during your pro exam, you will meet a lot of consultants, lecturers from internal and external. We're not sure yet how to do it during this COVID-19 pandemic. season, but inshallah, if worst come to worst, it will be the same as last year. So they will have patients, long case, short case. I'm not sure yet how it's going to be conducted. Okay, so not to worry about that, but worry about your own self, your own study, your own knowledge and skills, inshallah. Okay, first of all, we must, uh, what do you call it? Clarify our niyat of today's session. What is our niyat? Not only for your pro exam, okay, inshallah. I'm not preparing you for pro exam, to be honest. I'm not preparing you for end of posting, department ONG, block. No, I am preparing you, inshallah, for your future as a doctor, for you to take care of your patient, for you to be able to join in the discussion with the MO and the specialist and the consultant, quoting this guideline, quoting that guideline, evidence-based medicine. I think that's what all doctors should be doing. Okay, not only specialist and consultant, but also the MO and houseman, as well as medical students. We always appreciate a good discussion on evidence-based. Okay, so we give you a little bit of outline first. What we're going to discuss about hypertension in pregnancy, the different types of hypertension classification, okay? Measurement of BP and proteinuria. It surprised me that a lot of people still don't know how to take blood pressure measurement. It surprised me that you don't know how to do protein dipstick. Okay, a little bit of a advanced topic, prediction and prevention of preeclampsia. If you know this topic and you're able to discuss it well, distinction level, inshallah. Who wants to get distinction?
Me.
Alhamdulillah. So you declare it to the world already. Okay. Management of chronic hypertension, management of gestational hypertension, and preeclampsia. Okay, intrapartum care, management of emergencies, and then postpartum care. I think this would be a good outline for all of us because these are the most common type that we will see, okay, throughout your career, inshallah. Okay, so the main types are chronic hypertension, or some people call it essential hypertension, gestational hypertension, preeclampsia, white coat hypertension, mass hypertension. Okay, some definition. Chronic hypertension are those detected before 20 weeks. Okay, before 20 weeks. That's the that's the definition, the first half of pregnancy, because we think that if the hypertension occurred due to pregnancy, it will occur after 20 weeks gestation. It's part of the trophoblastic invasion causing physiological drop of blood pressure during the second trimester. Okay, most people will drop their BP in the second trimester, but those who maintained at a higher level, those are highly likely to be essential hypertension in the beginning. If it's later, it's probably gestational hypertension. Okay, preeclampsia. Okay, throughout my I can't remember how many years now. 17 years. Okay, 17 years being a doctor, the definition of preeclampsia has changed a few times. Okay, so during my time, during my time, preeclampsia was threefold, and high blood pressure, proteinuria, and edema. Okay, and then a few years later, edema has been scrubbed from the definition because a lot of normal pregnancy also has edema. Okay, and then recently they have changed it again. Proteinuria is not compulsory. Okay, it can occur and it can occur even without proteinuria. Okay, so high BP is still there. So plus or minus proteinuria and stroke or an organ damage. Okay, liver impairment, kidney, neurological, hematological, particularly the hemolysis and thrombocytopenia, or fetal growth restriction, fetal affected. Okay, so nowadays, high blood pressure with one end organ damage occur during pregnancy above 20 weeks. Okay, above 20 weeks, it is called pre-eclampsia until proven otherwise. Okay, white coat hypertension is when your high blood pressure only occur during clinical encounter. Okay, they become nervous, they become scared, anxious, seeing a doctor, then they get high blood pressure. Mass hypertension is the opposite of white coat hypertension. They have normal BP during clinical encounter, but high during other time. These are people who have self-monitoring blood pressure. They do it at home, it's high. When they come and see doctor, it's normal. And so they still have the risk of high blood pressure complication. So don't take it lightly, okay? Next would be how to measure BP in pregnancy. Okay, when you observe blood pressure being taken in the ward, in a clinic, sometimes they're not doing it right. Okay, we used to use the mercury sphygmomanometer, right? But there are concern about mercury use that in Europe nowadays they have stopped using mercury sphygmomanometer. Okay, so now we are changing towards electronic device that can measure blood pressure, but these electronic device need to be calibrated and certified that it can be used in pregnancy. Okay, so that's about the equipment. About patient position, okay, what's the best patient position to measure BP? Let's ask some students. Anis Akila, what do you think? How do we position the patient when you want to take blood pressure? Anis Akila,
Ya doktor, saya
ha?
dengar ke doktor?
Dengar.
Dengar. Ah, the best position is sitting position lah, patient. Sitting position.
Sitting position, yes, you're right. If the patient cannot sit,
Ah, kita prop up katil patient 45 degree.
good. Prop
Prop
up
up.
is better. Okay, kalau dia tak boleh prop up, ni macam apa, solat lah pula solat untuk orang sakit. Kalau tak boleh berdiri, duduk. Kalau tak boleh duduk. Ni kan. If they cannot be propped up, you can do left lateral tilt. Kan? Left lateral position, about 30 degree should be enough. You don't have to go all lateral. Okay, 30 degree lateral tilt is sufficient to release the aortocaval compression. Okay, but when you tilt the patient, which arm do you take for your BP measurement? Do you take on the left side or the right side? Faris Hisham, what do you think? Which arm do you prefer to take blood pressure?
Right?
Right. Why?
Allow left lateral position. Okay.
Okay, when the patient is turning left, so the right side will be on the upper part, isn't it? So it's going to be wrong. Okay, because it's not at the same level as your heart. Okay, the blood pressure cuff should be at the level of your heart. So preferably you should get the patient arm, the left arm forward. So when you tilt, the upper arm is at the level of the heart. Take the pressure. Okay, that will be a better estimation of the blood pressure in women. Okay. Anisakila, you're right. The best one will be sitting. So there's no aortocaval compression at all. Patient in clinic, for example, patient in the ward, you can ask them to sit first. it will show that they still have the strength and to sit up. Okay, so that is the best position actually. Calf size. There are several calf size nowadays. 40 to 50% patients population are overweight and obese. So you need to use a larger calf size for these women. Otherwise, your measurement will be wrong. Okay. The inflation part. The inflation, when you inflate the calf, you have to palpate the radial pulse. Okay, when you palpate the radial pulse, you inflate until the radial pulse is diminished. That will be your systolic blood pressure, and then you inflate a little bit more, about 20 millimeter mercury more. Okay, and then when you want to deflate the cuff, you deflate it slowly. Okay, about 2 millimeter mercury per second. Okay, 2 millimeter mercury per second, so that it will take about 30 seconds for you to get a good blood pressure reading. Okay, 2 millimeter mercury per second will also tell you that when you want to present your blood pressure, it should be in 2 millimeter mercury accuracy. Okay, most of the time, most doctors, most nurses, they will give in 10 millimeter mercury accuracy and 110 over 70, 120 over 80. It's sort of like a script that you have memorized already, isn't it? So that is not good. Okay, you have to tell up to 2 millimeter mercury accuracy. Okay, I want to see during end of posting or during pro exam, you tell us blood pressure is 182 over 86. Oh, so that's very high, isn't it? 182. 128 the other way around. 128 over 86 millimeter mercury. Okay, something like that. So it shows that you're not rounding up or rounding down your blood pressure measurement to 10 millimeter mercury, which is a bad habit. Okay. Korotkoff 4 versus 5 in pregnancy. Which one do you prefer? Which one is the best in the latest guideline? Any idea? Hazrik Arshad? Hazrik Arshad, can you
Yeah,
tell
doctor.
me? What do you think?
Yes.
Korotkoff 4 or 5 for diastolic measurement?
Sorry, doctor. I don't know what is Korotkov is.
Oh my God. Hazrik. Okay. You disappoint me, Hazrik.
Sorry, doctor. I will can I read right now?
Okay. Let's try another person. Aklan Zaki. Aklan, come on. Korotkov 4 or 5? Which one do you think is the best for blood pressure diastolic measurement?
Hello, Doctor.
In
Sorry.
yeah.
In pregnancy, in a normal Korok of 5, but in pregnancy, I think it's 4, Doctor.
Okay. It used to be like that. But the latest guidelines still say Korotkov 5. Okay, Korotkov 5 is when the sound disappear. Okay, the sound of the heartbeat disappear. Korotkov 4 is when the sound is muffled. It doesn't sound that clear. Okay, there's some turbulence. That is Korotkov 4. Okay, Hazrik, you need to know Korotkov 4, Korotkov 5. Okay, you
Okay,
need to
doctor.
know. Korotkov 5 is when the heartbeat disappear. So that is more what do you call it? More correlate to the blood pressure punya complication. Okay. It used to be Korotkov 4 like Aklan said in pregnancy, but because they thought the in pregnancy state is hyperdynamic state. Okay. However, those who do not have Korotkov 5, where the heartbeat can be heard even down to 0, those cases are very rare. Okay, I've never seen one actually. It's always disappear. The one that I've seen in the last 17 years. Okay, so I agree with Korokov 5 according to latest guideline. Okay. Some guideline suggest do multiple reading. Okay. Some people automatically do multiple reading because they think, oh, it's a bit high. Okay. They do another reading. And then, oh, the second reading is normal. So which one do you take? Okay. Are you going to record the high one and act upon it? Or are you going to record the normal one and don't do anything? Which one do you think? Let's ask Afifah Sofian. Afifah Sofian, what do you think?
Sorry, doctor. Again, the question.
When you take blood pressure, multiple reading,
Yeah.
okay, one reading is a bit high. Let's say 140 over 90, okay, and then you take it again because you want to make sure. And then the second reading will be 132 over 88, which is, borderline. And
I
which
think
one would you record?
I'll record the second one. Because the patient may be a little bit relaxed because previously the patient is not relaxed. So when we repeat, the reading is lower, can.
Then you have an observer bias
Oh.
because you want the patient to be normal. So you take multiple reading, okay, and then now it's normal. Oh, the patient is less anxious now. Now it's normal. Okay, take the normal one. It's going to be dangerous. Okay, because the patient could be mass hypertension, like earlier I said. During other time, the BP could be even higher, kan? So if you take the normal one, you risk being negligent. I mean bukan negligent, complacent. You rasa macam dia tak ada apa-apa, dia okay. Faham tak? You don't tend to start medication ke apa kan. So the guidelines say when you take multiple reading, you should average it. Okay, you should average the systolic, average the diastolic. So don't take many times, then it's going to be difficult to average. Okay, maybe maximum 2 or 3 times, then it will be easier. Okay,
All right.
maximum. All right, good, excellent. See, I told you a lot of people don't know how to take blood pressure. Proteinuria. Okay, there's several ways to quantify proteinuria. Okay, the easiest one will be urine dipstick that we usually do in clinic. However, the urine dipstick in clinic is according to our visual. Okay, because the color of the urine dipstick will change very slightly. It's slightly green, slightly yellow. It's difficult to tell. You compare it to the bottle punya label tu, but it's still a bit difficult to tell. Okay. So they suggest you use a machine with automated urinalysis. Okay, a machine will give a more precise colorimetry, and okay. And then if it's what's the level significant for pre-eclampsia? Anybody know? Adin Nur Hakim.
Yes, doctor.
Apa tu kalau
So,
urine dipstick proteinuria apa yang significant? 1
significant
plus,
untuk
2 plus, 3
urine
plus.
dipstick is more than 2 plus. 2 plus or more.
Betul. 2 plus or more correspond to 300 milligram.
Yes.
Okay, good. Lepas tu, if it's like that, you want to confirm it. Okay, you can confirm it with PCR, protein creatinine ratio, or albumin creatinine ratio. It depends on your lab, your preference. Okay, we are moving away from 24-hour urine protein collection because it's going to be difficult for the patient and for the nurse semua, and it's going to be a wasting of time as well. Okay, because patient might have pre-eclampsia, we want to act earlier rather than later. Okay, we don't want to waste time collecting 24-hour urine protein before we diagnose pre-eclampsia. Okay, and do not use the first catch morning and during the morning urine for proteinuria test. Okay, let the patient have breakfast first. Okay, after a couple of passing urine, then you can do your urine test for proteinuria. That will be better because during the night we afraid that the urine become so concentrated. Okay, a lot of the time kan, early morning when you pass urine, the urine is concentrated because you're not drinking for the last 8 to 10 hours. It's going to be misleading. Okay, it could be higher than normal level.
Doktor, untuk
Yes,
yang midstream atau apa? Yang midstream tu still kita perlu bagi tahu patient ke?
it will be the best. Midstream will be the best. It reduce contamination as well. But this first catch morning urine ni maknanya not the first time dia pass urine during the morning lah. After the breakfast apa mungkin during the later that morning punya urine sample yang kita hantar. Midstream tu sebab dia nak kurangkan contamination. Okay, so ask them to pass urine a little bit, hold and then put the bottle there and then baru collect dia punya urine sample. That's the midstream urine lah. Okay, it's good for kalau nak hantar CNS juga midstream urine. Okay, a little bit advanced. Nowadays we're talking about prediction for pre-eclampsia. Okay, there are a few things that can be done. Okay, but they are not strong. There are no strong evidence yet which one is the best. Okay, some guideline nice guidelines suggest placenta growth factor. Okay, but it's not available everywhere. Okay, in Malaysia, placenta growth factor and S-fleet one, there's another one, is available privately, but it's not not routinely used. Okay, because they have to pay for it, and it can predict preeclampsia for up to 1 week. Okay, this is maternal risk factor is what we usually do kan. Dia ada hypertension sebelum ni ataupun kidney disease, autoimmune disease, macam-macam lah risk factor tu kan. Blood pressure and MAP. MAP ni apa? Mean arterial pressure. Do you know how to calculate mean arterial pressure?
Yes.
Let's hold on, Nadine. I'll ask someone else. Amalia Zulkifli. Do you know how to calculate MAP, mean arterial pressure? It's okay if you don't know. I'll ask someone else. Okay. Anati Zahra. What do you think? Anati Zahra, do you know how to calculate MAP?
I think doktor dengar ke?
Ya, dengar.
Diastolic BP plus 1/3 of systolic.
Tak berapa tepat. Tak berapa tepat. Tak berapa tepat. Contoh 120/80 contoh kan. Kalau guna you punya formula, diastolic ialah 80. 1/3 of systolic ialah 30. So dah jadi 110. Tinggi juga tu. 120/80 bukan 110 dia punya MAP. MAP, cara yang paling senang nak kira, okay, the easiest way to calculate MAP ialah the difference between your systolic and diastolic. The difference. That difference you divide by 3. And then you add your diastolic. Okay. Not the whole systolic you divide by 3, but the difference between systolic and diastolic. Okay. Let's say blood pressure 160/110, which is severe hypertension and severe preeclampsia. So you have the difference is 160 minus 110, which is 50. Divide by 3, that is berapa? 50 divide by 3, 18 lebih kurang kan? 17.6666, something like that. Okay. Add your diastolic, which is 110. So they're 127 already. That is very high. Okay. Anything more than 125, you need to admit patient, you need to give parenteral IV, antihypertensive, okay, labetalol, hydralazine. Okay. Uterine artery Doppler can be used in the first trimester pun boleh, second trimester at 20 weeks pun boleh. to predict pre-eclampsia. However, dia punya evidence is not that strong. Okay, these are for mention only. If you mention this, the examiner will be impressed. Okay, distinction. Okay, siapa nak sila ambil. Tak nak sudah. Prevention. Okay, nowadays people talk about prevention of preeclampsia as well. Okay, aspirin 75 to 150 milligram OD. This is Aspirin trial. Okay, Aspirin trial. So it can reduce incidence of preeclampsia significantly. Calcium supplement for those who are lacking in dietary calcium. Okay, this is WHO guideline. There's no role for other types of prevention. Okay, diuretic, progesterone, low molecular weight heparin, folic acid, fish oil. These are all in the guideline. They say there's no role. Okay, no role of dietary salt restriction. General lifestyle advice are the same as healthy women. Okay, achieve ideal weight, exercise. Smoking. What do you think? Does smoking, stop smoking prevent high blood pressure? What do you think? Let's go lower down the alphabet. Rahil. Siapa Rahil? Alamak, alamak. Hidayah Munir. Hidayah Munir. What do you think about smoking and blood pressure in pregnancy? Do you have any idea?
I'm not sure, Doctor.
The thing about smoking, in preeclampsia, okay, it has surprisingly a little bit of protective effect. I don't know why. People still cannot find out why those who smoke has lower incidence of preeclampsia. However, okay, there's a big however, big but. Okay, if they get preeclampsia, they are highly likely going to get the severe form. Okay, so they have protective effect against mild preeclampsia, but if they get preeclampsia, they're going to get the more severe form. So the general advice to stop smoking is still there. Okay. All right. I will make it a little bit quicker because we only have 15 minutes left for this topic. Aspirin. Okay. A lot of indication nowadays to give aspirin. Previous high blood pressure in pregnancy, chronic hypertension, type 1, type 2 diabetes, autoimmune disease, chronic kidney disease. These are major risk factors for preeclampsia. You give aspirin. Okay. If you have 2 or more moderate risk factors, such as primigravida, being the first pregnancy, age more than 40, pregnancy interval more than 10 years, booking BMI more than 35, history of preeclampsia or multiple pregnancy. Okay, so if you have 2 or more moderate risk factor, you start aspirin. How to take, when to start? Let's see. Nurul Amirah Ahmad. Ada 2 Nurul Amirah. Nurul Amirah Ahmad, what do you think? How to take aspirin? Apa kita advise patient?
Aspirin we take start on 16 weeks until delivery.
Okay, you're almost correct.
Okay, 12 weeks.
12 weeks,
12
betul.
weeks until delivery.
The best would be 12 weeks. You can give up to 16 weeks. That is the best effect until delivery. Tapi if you can start even up to 28 weeks, you get some benefit but not ideal. Okay. Some people advocate to stop at 36 weeks because they are afraid of the antiplatelet effect of aspirin. Kan? Because patient will go into labor, takut bleeding banyak kan. So, but the latest guideline semua kata boleh up to delivery. Okay, when patient come in labor, stop taking aspirin, don't take it anymore. Okay, so if you want to quote guideline, you can quote nice guideline. You can quote Malaysian CPG on hypertension, and including a segment on hypertension in pregnancy. These guidelines I already um, shared with you in the attachment part of this Google Meet section. Okay, you can download it. Hopefully, any problem, let me know. I can share through WhatsApp. Okay. So let's go to management. If patient has chronic hypertension, you have to treat as high risk, okay, for pre-eclampsia and stroke, okay. Stroke, it can happen as low as 155 millimeter mercury systolic, okay. Stroke is more towards systolic blood pressure, okay. Pre-pregnancy, you change the patient medication, ACE inhibitor, angiotensin receptor blocker, or thiazide, diuretic, because these are teratogenic, okay, congenital anomaly, causing fetus kidney problem, okay. In pregnancy, most common antihypertensive use are labetalol, nifedipine, and metadopa. Okay, metadopa has significant side effect, particularly feeling apa tu, malaise, depressed, rasa macam somnolence, macam ngantuk je depannya hari. Okay, labetalol, it used to be they were afraid of beta blocker because beta blocker was found to be associated with IGR. However, that was atenolol and apa tu, other types of beta blocker. Labetalol has been found to be safe to be used long term, okay, in pregnancy. So nowadays, labetalol is climbing up to be the first line medication, okay. Nifedipine as the second line. Okay, nifedipine is a calcium channel blocker, but don't take it sublingually. Okay, sublingually will tend to have crash BP, drop in BP. Okay, offer treatment if BP is high, more than 140/90. So you aim to be a borderline only. Okay, 135/85 borderline. You don't want to go down to normal 120/80 because you're afraid of fetal and placenta perfusion. Okay, they can have lower uh, apa tu fetal weight if you aggressively control the blood pressure until normal. Okay, fetal growth scan and uterine artery Doppler, you do it for all women with chronic hypertension at 28, 32, 36 weeks. Okay, 4 weekly. Timing of delivery depend on obstetric indication if they have worsening or problem. Okay, preferably at term. Okay, most of the time they don't wait post date. Okay, most of the time they induce around 38, 39 weeks. Okay, postpartum we stop metaldopa because they have higher risk of postnatal depression. Okay, and consider other antihypertensive. I will tell you later for postpartum antihypertensive. Okay, and then review again at 6 to 8 weeks because most of the time all the pregnancy effect are already gone at that time. You want to review and check the antihypertensive everything as non-pregnant women. Okay. Management of gestational hypertension or pregnancy induced hypertension, it depends on which guideline you follow. That's the name, the terminology. Okay, if it's severe, more than 160/110, you need admission. You need parenteral IV antihypertensive. Okay, but if you were in clinic, it's difficult to get your IV access, labetalol or anything. You can give nifedipine first, nifedipine stat. Okay, as a houseman, you have to ask your MO. Okay, you do not prescribe nifedipine yourself. You can prescribe paracetamol. That's it. I think as a houseman. Okay, don't prescribe something else without your MO punya permission. Okay, and you do weekly PE profile. Okay, weekly PE profile. PE profile include the basic one is FBC, liver function, and renal profile. The basic. Okay, uric acid nowadays, they don't act on uric acid only, so it doesn't change your management, so it's a useless investigation. Okay, LDH is for hemolysis indicator, but if you don't see signs of hemolysis, the HB is normal, the bilirubin is not high, then you don't have to do LDH. Same as coagulation profile. If the platelet is normal, then you don't have to do coagulation profile. Or if the LFT is normal, you don't have to do coagulation profile, because they will usually consume the platelet first before other clotting factor. Okay, so those are justification of your PA profile. If you can add those in your answer during exam, and why which investigation you want to do and PA profile, justify. Okay, fetal growth scan and uterine artery Doppler at diagnosis and 2 to 4 weekly, depends on the progress. If you think there's a sign of fetal growth restriction, you do it more frequent. Okay, consider PLGF measurement. Okay, placenta growth factor to predict preeclampsia within 1 week. Okay, timing of delivery as agreed by both obstetrician and women. Most of the time we wait at term, unlikely post date. Okay, postpartum, you stop metadopa, consider other antihypertensive, and then review at 2 weeks. If continue on medication, review at 6 to 8 weeks, ke have to refer medical if persistent. Okay, sebab apa tu, gestational hypertension kan in second half of pregnancy, you want to see if dia ni. Okay, the question about measurement of BP and MAP is every single clinical encounter. Okay, you see a patient, you need to take BP. That's why we ask you to take BP when you see patient in the ward and you see patient in clinic. Okay, our patient always have blood pressure measurement on every clinic encounter. MAP should be automatic in your head. Calculate the MAP, inshallah. Okay. Management of preeclampsia. This is the best part. So please don't get bored and please don't sleep at this time. Okay. It causes concern if systolic BP is very high, more than 160. Creatinine is high, 90 and above. Okay. In pregnancy, creatinine is usually low. So if it's 90 and above, it's already abnormal. Okay. ALT is 70 or more or double the normal range. Okay, platelet thrombocytopenia less than 150,000. Okay, and any signs of impending eclampsia, pulmonary edema, or suspected fetal compromise. These are the concerning signs that we need to admit and think of early delivery. Okay. Nowadays, they have prediction model, full Pierce and Prep S. You can search for it on Google. You can fill in the patient parameter. Okay, they ask you about the gestation, about the blood pressure and everything. They can calculate the risk of developing preeclampsia. This is interesting. It's in nice guideline. Okay. I've never seen it being used in Malaysia before. So if you can quote this, I think, you know, you're excellent. Treat if persistently high, and PA profile twice weekly. Kalau normal, preeclampsia yang mild. Kalau dah severe, 3 times weekly. Okay, and consider delivery. Okay, fetal growth scan and uterine artery Doppler, you do it every 2 weeks. Indication for early delivery. Okay, if you cannot control the BP even after 3 types of antihypertensive, semua dah pakai labetalol, nifedipine, metadopa kan. If they start to have low SpO2, maknanya dah macam pulmonary edema dah kan. Progressive deterioration of PA profile kan, sebab kita repeat PA profile after a few days kan. Ongoing neurological event, headache, visual disturbance, eclampsia, ni semua ni you need to deliver early. Okay, fetal Doppler, reverse end diastolic flow, CTG. Okay, Otherwise, aim delivery at 37 weeks. Pre-eclampsia, you don't have to wait 38, 39, okay? 37 je induce, okay? Because most of the time it will get worse before it gets better. And most of the time after delivery, it will get better, okay? But remember, pre-eclampsia and eclampsia can also occur in postpartum. So you still need to have frequent BP check and continue antihypertensive if they are already on antihypertensive, okay? Aim below 130/80 postpartumly because you don't care about placenta perfusion anymore, okay? And then reduce your antihypertensive or stop, okay? Review at 2 weeks kan. Selalu dia suka buat EOD BP every other day BP dekat KK ke ataupun JM datang rumah kan. Self monitoring of symptom, ask the patient to monitor dia punya symptom and apa tu, inform pergi hospital kalau ada symptom kan, sebab eclampsia can still occur up to 6 weeks of postpartum, okay. Alright, severe preeclampsia, we go into emergency management, okay. Severe preeclampsia or eclampsia, first thing first, you must stabilize patient. Okay, I remember OBA question. Okay, this is bukan soalan bocor because it's not your exam. Okay, which one you do first? Give IV Maxaf, secure the airway, give antihypertensive labetalol, deliver the baby. Okay, I bagi 4 choice lah dulu kan. Which one is your first initial management? OBA kena pilih yang mana satu kan. Semuanya rasa macam betul, betul tak? Semuanya betul. Yes, betul, betul, betul. OBA is one best answer. The answer is stabilize the patient, airway breathing circulation. Okay, well done. Okay. Saya pun salah. Saya ingatkan Maxaf. Nak? Rupa-rupanya the simple thing for if patient is not breathing, pulmonary edema, then can die within minutes. Okay. So recurrent fit, okay, IV Maxaf nanti waktu houseman nanti korang kena belajar lah. You need to know how to prepare the bolus. Okay, each vial is 2.48 gram and then you need to get 4 gram. So 2.48 is about 2.5. You get 2 vial, that is 5 gram. You need to get 80% of that. Okay, it's 10 milliliter, you get 8 milliliter of that, and then you dilute with your normal saline up to 20 ml. Okay, and then you give it slow bolus 10 to 15 minutes. This is the part where the houseman is very crucial. You need to sit there beside the patient, pressing the syringe slowly up to 10-15 minutes. Okay, that's your houseman job. Okay. It's not bullying. No, it's not bullying. It's somebody has to do it. Okay, followed by 1 gram per hour for 24 hours. You prepare that 25 gram kan. 25 gram in 500 ml normal saline, titrate using your drop meter kan, apa tu. Okay, if deliver during that time, you continue until 24 hours post delivery. Okay, if they have recurrent fit, you can give extra bolus 2 to 4 gram. All the other apa ni, diazepam, lorazepam, phenytoin, all the other anticonvulsant are not recommended. Okay, not recommended because you need to give magnesium sulfate first. Magnesium sulfate is cheap but save lives. Okay. Intractable severe headache. Okay, if they have impending eclampsia punya symptom kan, visual disturbance, nausea, vomiting, ni semua impending eclampsia punya symptom, you need to give IV Maxaf. Antihypertensive, labetalol, oral or IV, oral nifedipine, okay, hydralazine. Hydralazine nowadays kurang. We use it less and less nowadays. We prefer labetalol. Because labetalol you can give multiple bolus. Okay, and they have better control. Oral nifedipine is, of course, if you are away in KK or anything, you don't have easy access to IV, then you give oral nifedipine. Why are we so aggressive controlling blood pressure in pregnancy? Because stroke and eclampsia in pregnancy can occur very fast from low risk, and then they shoot up, and then they can get stroke or eclampsia very fast. Okay, some guideline, American guideline, they don't like the term mild preeclampsia because you tend to get complacent. Okay, so if it's preeclampsia, you have to be aggressive. Okay, even if it's in a milder form, in a stable form, you have to monitor and admit patient, monitor closely. If they get high, severe, you need to deliver early. Okay, right. Postpartum antihypertensive, when the patient is no longer pregnant, no longer worry about the placenta perfusion, no longer worry about teratogenic effect. Okay, you can choose other antihypertensive just like non-pregnant population kan. Tapi stop using metadopa because it has higher risk of postnatal depression. Okay, consider ACE inhibitor, enalapril, nifedipine or amlodipine. Amlodipine is a one daily dose kan. So it's a better compliance. Okay, and you can combine the two, enalapril and nifedipine as well, and you can add on atenolol, okay, beta blocker as a third line. Avoid diuretics and ARB. This is mainly because of breastfeeding. Okay, patient want to breastfeed, they need to be well hydrated. Okay, so avoid this type of antihypertensive. All right, that's all about hypertension in pregnancy. I will stop presenting and answer some questions if you have, and then we have a quick toilet break before we go on for diabetes. Let me turn on your chat if you have any question. Ta-ta-ta. For the prediction, I already answered regarding BP. Okay. In CPG, why they suggest metadopa as first line and labetalol as alternative first line? Okay, metadopa has a long history of safety in pregnancy. That's why people still prefer metadopa in some places. However, now we have labetalol, which has better side effect profile compared to metadopa. We are moving towards using labetalol nowadays. Okay, in Malaysian guideline, they follow US, I think, I'm not sure, but they can give labetalol up to 400 TDS. But if you follow UK guideline, you can even double it, 800 TDS. That's the maximum dose for labetalol. Okay, 2.4 gram per day. If you follow Prof. Imelda Balchin, she's a fetal maternal consultant who were trained in the UK, and she encouraged using labetalol as well, up to 800 TDS. Okay. Any other question? 5 minutes for question. Calcium supplement. Okay. Calcium supplement, you can start as soon as possible. It's basically for those who are lacking in dietary calcium. They don't like to drink milk. They don't have yogurt or cheese. Okay. These people are highly likely going to be lacking in dietary calcium. So we give supplement. Okay. What happen is during pregnancy, the baby, the fetus will absorb whatever it needs from the mother's body. Okay. If the patient does not have enough calcium, they will absorb from the mother's bone, from the mother's teeth. Okay, I've seen a woman, orang asli, she's only 28 years old, but she looks like a grandmother. Okay, because she has 12 children. She has been pregnant every single year since she was 16. Okay, she looks like a grandmother with no teeth at 28 years old. So it's because of calcium. Okay, measurement of PLGF routinely done? No. In Malaysia, it's not routinely done. In UK, it's consider offer PLGF to predict preeclampsia, but it's only for up to 1 week. in Malaysia, it's still under clinical research setting. Okay, in IUMMC, we've done it several times on our patient, and unfortunately, one patient died during the COVID-19 pandemic due to preeclampsia, and she also has bad obstetric history with a poorly controlled diabetes and everything. So she had a normal normal level of PLGF, but she died several weeks after lah. We did not repeat every week dia punya PLGF level tu. So that's a bit of a shame actually. Unfortunate. May Allah bless her in the hereafter. May you explain again regard weekly PA profile? Okay. PA profile, if you have gestational hypertension or if you have stable preeclampsia, no, PA profile in gestational hypertension, you do it weekly. That's according to the guideline. If you have a stable preeclampsia, you do it twice weekly. Okay. It can be outpatient even sometimes if they are stable. Okay. If patient is unstable, they may admitted for hypertensive crisis or anything. You do it 3 times a week. Okay. Basic PA profile is FBC to look for thrombocytopenia and signs of hemolysis, and then you do LFT and you do your RP. Okay. The rest uric acid, LDH semua tu second line. Okay. Uric acid is being phased out. We don't act upon it, so it doesn't change your management. So it's a waste of time and money and energy. Doctor, is there any different diagnosis and prognosis for PE that occur de novo or superimposed chronic hypertension? Okay, I'm not sure exactly the difference, but I think both of them are serious matter. Okay, preeclampsia is a serious matter. It can turn into severe and eclampsia in the nick of time. I mean, in a short period, and we need to be vigilant and we need to treat very quickly lah, timely manner. Superimposed chronic hypertension punya PE pun lebih kurang sama juga. Okay. The superimposed chronic hypertension tend to have more severe type because most of the time they already have an organ damage, kidney problem, heart problem, they get pulmonary edema and stroke pun in higher incidence. Okay, I think shall we stop there? I want to have a quick toilet break and then we move on to diabetes. Okay? Sekejap. Okay, insyaAllah. Assalamualaikum warahmatullahi wabarakatuh. We will continue. I think there are a couple more questions in the chat room about chronic hypertension. Do we do weekly profile? I don't think we need to do weekly PA profile, but we need to do a baseline to check for an organ damage. And then if we suspect that she possibly have developing preeclampsia, then we can do a PA profile then. So I'm a bit confused about the term severe PE and impending eclampsia. The impending eclampsia is when you have the symptoms, okay, the headache, which is intractable, you cannot treat with paracetamol, okay, and it's more of a generalized headache, okay, not just localized frontal or occipital, okay, or tension headache on the side, okay, that's a different. Pending eclampsia punya headache dia generalized and is throbbing because of the blood pressure kan. Okay. Itu yang lain-lain apa visual disturbance kan, nausea, vomiting, epigastric pain. You need to know the pathophysiology of all these symptoms as well because some of the lecturer love to ask about the pathophysiology of the symptoms. Okay. Hepatocellular necrosis, intracapsular hemorrhage, and that sort of thing. You can read it, okay? So severe preeclampsia, is when the blood pressure is very high, more than 160, 110. You need intravenous antihypertensive. And HAP syndrome is a type of severe preeclampsia as well. Okay, anything that is causing organ damage is also severe preeclampsia. Okay, pulmonary edema, all those things. Okay, if patient with chronic hypertension and having high risk PE, even though BP is still stable, should we admit this patient? If the BP is still stable, we can treat as outpatient. Okay, inshallah. When someone is newly diagnosed with secondary hypertension during pregnancy, management berbeza ke? Okay. Secondary hypertension, okay. Management is similar to chronic hypertension, but during pregnancy, we are more vigilant because we want to look for preeclampsia. And then we continue until postpartum up to 6 weeks. And then after 6 weeks, we are quite sure that it's no longer preeclampsia. You can treat and you can investigate further for secondary hypertension. Okay, pheochromocytoma, semua lah benda-benda tu. Okay, hopefully it's well controlled. All right, so the next topic we will continue with diabetes in pregnancy. I will share the slides. Right, so diabetes in pregnancy is another common questions. It can appear in your MCQ, on your EMQ, in your PMP, long case, short case, everything. Okay, you bound to get a patient diabetes. You can see a patient with diabetes in labor on your first day as a tagging houseman. Okay, so you need to know 100%. You need to read the CPG Malaysia guideline 2017, which came out in 2018. Okay, you need to know the guideline inside out so that you'll be able to manage your patient properly. Okay, you'll be able to join in the discussion with MO and specialists regarding the management of the patient. Okay, so what you say is evidence based. Inshallah, that's what we want. Okay, future doctor. Let's start. Outline is a bit easier compared to hypertension, I think, in my opinion. Okay. Screening, preconception care, antenatal, labor, postpartum. That's my outline. It looks easy. Okay. But the disease is more difficult, I think, to control. Okay, let's start with screening. Okay. So screening, we use risk factors. Okay, in Malaysia, we still select patient. But the latest guideline, you're starting to do OGTT on almost everyone. Okay. Patient age 25 with no other risk factor, you do OGTT once at 24 to 28 weeks. So it's almost all pregnant women. So in Malaysia, we prefer OGTT, 75 gram glucose at booking if they have any risk factor other than just the age factor. Okay, and if negative, you repeat at 24 to 28 weeks. Okay, why? Because nowadays at booking, we want to detect overt diabetes. Okay, that's the relevance of the booking OGTT. Okay, the repeat at 24 to 28 weeks is for the developing insulin resistance in pregnancy, the classical gestational diabetes mellitus. Okay, so what is the level for Malaysia? Fasting blood glucose and 2 hours post 75 gram. Let's ask someone. I hope you can participate and give me the right answer. Siti Hajar. Siti Hajar, can you tell me about OGTT level in Malaysia? What do we use according to the CPG? Siti Hajar Zulkifli. Hajar, where are you? Tak menyaut.
Doktor nak jawab boleh? Tadi saya jawab tak boleh.
Okay, silakan.
Ni soalan ni saya dapat masa saya remedial ONG masa year 3. So saya nak try jawab.
Alhamdulillah. Okay.
The soalan doktor OGTT kan?
Ya, betul.
Okay, kalau GDM dulu 5.6. Kalau diagnose dia sekarang FPG it will be 5.1 already. Kalau over DM it will be 7.8. Kalau 2 hour postpartum that's for FPG. 5.1 to 6.1 7 sorry. For over DM it will be 7.0 above and above.
Yeah.
And kalau over DM dia punya 2 HPP would be 11.1 2 HPP dia over DM. Kalau 2 HPP
GDM
GDM would be 5.1 to 6.9.
tak betul.
Tak ingat pula. Over DM.
OJTT.
OGTT.
You jangan confuse Hazri. You asingkan jawapan you. GDM berapa, lepas tu kalau over DM berapa. So kalau GDM Malaysia ambil 5.1 7.8. Okay, kalau over diabetes 7.0 11.1. 7-Eleven lah senang. Okay, you remember the store 7-Eleven, that is over DM. Okay, they sell a lot of carbonated sugary drink kan. So you remember 7-Eleven is over DM. Okay. Yang Malaysia punya 5.1 7.8. Okay, they're following HAPO study. HAPO study. Okay, it's a very famous international study, HAPO study. They noticed that the complication of GDM nowadays occur in even lower blood glucose level. So that's why they bring down the level from 5.6 to 5.1 sekarang ni, because they want to diagnose more so that they can manage better. Okay, good. So we already talked about over diabetes as well. Risk factor lebih kurang sama macam dulu-dulu punya BMI 27. In Malaysia kan obesity kan BMI lower kan. They get obesity complication at a lower BMI compared to WHO punya level 30 kan. So in Malaysia they use 27. Okay. Previous GDM, family history, first degree relative with diabetes mellitus, history of macrosomia. Malaysia macrosomia at term dia pakai 4 kg. Kalau Caucasian dia pakai 4.5. Okay, depends on body build juga semua kan. Bad obstetric history kan. Glycosuria 2+ on 2 or more occasion. Current obstetric problems such as hypertension, polyhydramnios, steroid use. Okay, you do OGTT. Okay, age 25 with no other risk factor, you do OGTT once at 24 to 28 weeks. Over diabetes should be managed as pre-existing diabetes. So you need to do screening macam-macam, neuropathy, nephropathy, vasculopathy, eye test and nephropathy, retinopathy for patient you diagnose over diabetes. Okay, preconception care, these are latest things, update in diabetes. We need to do preconception counseling. Okay, it's a multidisciplinary approach because a lot of the time they don't see ONG doctor before they get pregnant. So KK doctor, medical doctor who see diabetes patient, and if they are in reproductive age, okay, nowadays even if they're not married yet, okay, you need to think about reproductive. Okay, not all are RIUM students, not all are RIUM community. Even RIUM community sometimes terjebak dalam maksiat kan. So we take care of their health. We need to make sure they are good control with their with their diabetes control. Okay, what is the target level for HbA1c pre-pregnancy? Let's see. Nadia Farhana, what do you think? Nadia Farhana, What's your target level of HbA1c before pregnancy? Nadia Farhana nak cuba jawab. Kalau segan tak apa, saya bagi orang lain pula. Siapa lagi? Nurul Hidayah Muhammad. Nurul Hidayah.
Ya, doktor.
HbA1c target before get pregnant.
Less than 6.5.
Less than 6.5 is good enough. Yes. Well done. Okay. Preferably ideally 6.1 tapi 6.5 pun dah good enough. Okay, acceptable. Well done. Okay, kalau more than 10%, they have higher risk of congenital anomaly. Okay, congenital anomaly. Qayyum Rosli, what do you think are the most common congenital anomaly in diabetic mother? These are common question. I love to ask this on UIA student. Qayyum, are you there? Tak, Qayyum tak menjawab. Okay, let's see siapa lagi. Sharafina Adani, do you know what are the most common congenital anomaly in diabetic mother?
I think the most common anomaly is congenital heart disease.
Congenital heart disease, eclampsia, neurotube defect, good. So those two are the most common actually. Okay, good. Well done, Shafiq, VSD. I've seen one during my master exam. I've seen holoprosencephaly. Okay, is abnormal in the brain development. Okay, holoprosencephaly, the brain doesn't really form, so very poor prognosis for the baby. Okay, if the baby with no brain. So let's hope that the patient can control the diabetes even before they get pregnant. Okay, the patient should be on contraception before until the medical condition are well controlled. Okay, folic acid needs to be given high dose. Okay, what is high dose folic acid? Is 5 milligram. Is it 5 milligram? Yes, 5 milligram. 5 milligram once a day. Actually, in Malaysia, we only have 5 milligram dose. Okay, we don't have the 400 microgram punya dose. In the UK, they have a tiny folic acid tablet, 400 microgram. Okay, so in Malaysia, we give high dose folic acid on everyone. No problem, because it's only a supplement. Okay, it's a vitamin, so you can give. That's fine. So it can also prevent neurotube defect and macro apa? Anemia, macrocytic anemia. Okay, folic acid. Weight, okay, ideal weight is the best. Exercise, we encourage them to do daily exercise, 30 minutes at least. So at least 150 minutes per week. So it will help with the weight management as well. Aspirin, patient with type 1, type 2 diabetes is indicated for aspirin from 12 weeks, preferably up to 16 weeks, ideally. Okay, but they can still have benefit up to 28 weeks to start. Screening, like I said earlier, we need to do screening, eye test, apa banyak lagi, kidney, kan. When do we need to initiate folic acid? Folic acid preferably 3 months before you try to get pregnant. Okay, yes, 3 months before conception is the best, because by the time you know you're pregnant, the neurotube has already closed. Okay, so neural tube is one of the first development in the fetus embryology, kan? So by the time you know you miss your period a few days and you do your urine pregnancy test, neural tube has already closed by then. I mean, yes, we want it to be closed, but if it has defect, it is already defected by then. Okay, so you want it. So that's why we call family planning. When you plan to get pregnant, you need to take your folic acid, okay, contraception until you're actually ready. Okay, so we need to educate our women, our masyarakat. Okay, antenatal management. Sorry. Okay. Okay, nampak. Antenatal management, ideally we do self-monitoring of blood glucose. We educate our patient, but the blood glucose machine, they have to buy and the strip as well, and it's a bit costly for some people. So that's why if they cannot afford doing self-monitoring, they need to come and do it in klinik kesihatan kan. So klinik kesihatan cannot do it every day. So they have to do it once a week or twice, once in a 2 week time. So it's not ideal. Okay, the ideal way is to have self-monitoring blood glucose. If you read in the guideline, they specify if you are type 1, how many times per day you need to do. Type 2, how many times per day. If your diet control, berapa kali kan. Okay. So what is the expected level for monitoring blood glucose? That's another thing that you need to remember other than OGTT level. Let's see who's available. Muhammad Shakir Nabli. Muhammad Shakir. Can you tell me, Shakir, the level for BSP, blood sugar monitoring?
For fasting,
Fasting berapa?
fasting less than 5.3.
Betul.
1 hour postprandial 7.8.
Betul.
2 hours postprandial 6.7.
Betul. Excellent. Well done. So when you ask patient to do it according to the guideline, nak kena buat berapa kali apa semua, kan? Kalau poorly control, you admit, you do 7 times, 7 time BSP kan, before and after meal apa semua. So you need to correlate with how long since the last meal. Okay, pre-bed punya measurement taken before bed pukul 9, pukul 10 malam, it should be a 2 hour postprandial punya kan. Okay, so 6.3 is not necessarily abnormal kan. Kalau dia postprandial, it's still normal. Okay, up to 6.7 kan kalau 2 hour postprandial. Okay, medical nutrition therapy or dulu-dulu dipanggil diet control kan. And now if you use the term medical nutrition therapy, so you're up to date with your guideline kan. Medical nutrition therapy involve meal plan, carbohydrate control, and weight monitoring, and include exercise as well. Okay, this is medical nutrition therapy. You give them time from the diagnosis. You give them 1 to 2 weeks, okay, to do medical nutrition therapy. You can refer to dietitian at that time. If they cannot control the blood sugar profile during first 1 to 2 weeks, start them on metformin. Okay, this is in the guideline. It used to be start on insulin kan, tapi nowadays we change to start on metformin. If they already on metformin before pregnancy, they should continue, okay, on metformin in pregnancy. Before this, they were afraid of teratogenic effect or side effect of metformin pregnancy, were unsure. But according to latest guideline, they have a good safety profile now. So we are moving towards using metformin. Okay. During preconception care, apa tu, we use in tak apa, nanti tercerita. Insulin in pregnancy, we prefer multiple daily injection punya regime. Okay, we we use the mixture punya mix start apa ke, less and less in pregnancy. If we want to use it, we usually ask for medical and endocrinologist punya consultation lah before we use that. Because in pregnancy, we want to keep the blood sugar stable most of the time, and when they have meal, they have higher need for insulin, so we want to control like that a bit more vigilant actually. I mean a bit more strict compared to non-pregnant women, because we want to keep the blood sugar in the level of 4 to 7 maximum most of the time. Okay, we want to try to be strict as possible with your BSP. Okay, in labor and up to 7 pun allowable. Okay, ultrasound, we do the first trimester scan, we do the detail scan, we do serial growth scan 4 weekly from 28 weeks. These are for apa tu, pre-existing diabetes. Okay, kalau dia gestational diabetes, they're less likely to have congenital anomaly. Okay, the most they can get is microsomia and polyhydramnios. Okay, for gestational diabetes. So these are for these routine first trimester detail scan are for pre-existing diabetes. Okay, gestational weight gain is another favorite question Prof always ask students. Okay, what do you expect the weight gain? These are from the US punya finding. Okay, it's in our guideline. So in NICE guideline UK, they don't care about weight gain. Okay, in the UK, they said is the range is so big that it's you don't need to do you don't need to monitor it as strict as the US does. Okay, so Malaysia like to follow UK sometimes, and then they like to follow US sometimes. So in our guideline, we have the gestational weight gain following the US. Okay, you need to remember this. Intrapartum management, you maintain the blood sugar 4 to 7, and if it's more than 7 persistently, you consider insulin infusion, okay, according to your local guideline. In the CPG guideline, they give a suggestion on how to titrate the insulin. You can use that, okay. Make sure you include dextrose and potassium as well because of the metabolic punya diffusion. Postpartum, most of the time the insulin need will be reduced. Okay, so we will reduce the dose, or sometimes we can even stop the dose of insulin if the initial dose, antenatal dose is already low. Okay, and then you do OGTT at 6 weeks, and if negative, you need to do annual screening. Okay, this is what a lot of people forget. Okay, when you are working in the KK later, you need to do annual screening for those who had GDM during pregnancy. Okay, because they are at higher risk of developing DM, and DM, if it's not detected early, it will be apa ni, jadi makin teruk, makin tenat kan, affecting end organ damage, gangrenous foot semua. Baru nak tahu dia ada diabetes, lambat lah. Tahu nak? Okay. Right. So that's all about my GDM, diabetes and pregnancy. I would like to open for discussion, questions. Do you have any question? You can write in the chat room, or you can turn on your mic and ask. I don't mind. Medication modification during preconception care. Do we practice that? Yes. Okay. Patient who are reproductive age, we prefer to give medication that are safe to be used in pregnancy. Okay. Patient who are hypertensive, for example, we prefer to avoid ACE inhibitor, angiotensin receptor blocker, and thiazide diuretic because those are teratogenic to the fetus. Okay. Patient who are epilepsy, We need to control the medication, try to avoid polypharmacy, and choose the one that has less teratogenic profile. Okay, anticonvulsant, antiepileptic, semuanya ada side effect, semuanya ada teratogenic effect. However, you need to control the epilepsy with the lowest lowest effective dose. Okay, so I will stop the slide presenting. You can see your face. Right. Any other question?
Doktor, sorry tak boleh buka kamera, tak tahu kenapa. I would like to ask about how do I differentiate self-monitoring blood glucose from BSP. From what I know, BSP is done at clinic, while self-monitoring blood glucose is patient done itself. And what I understand some more is that not all patient was able to do that due to nak beli glucometer lah and to
Betul.
advocate. So any other differences, doctor?
The other differences is in the latest CPG, we are trying to educate our patient to take care of more of their own health. Okay, kalau BSP, do you do it once a week or once in 2 weeks time? Patient, a lot of them tend to control their diet 1 or 2 days before BSP day. Okay, it's going to have a false negative punya result. Tahu tak? During BSP nampak cantik je, tapi baby still macrosomic ataupun they still get complication of diabetes. So rupa-rupanya they, you know, it's a bad attitude of Malaysian population where they try to cheat the doctor, but actually they are cheating themselves. Okay, it happened a lot in Malaysia. If there's a way you can cheat the system, they will cheat the system. So it's something bad because the problem will only be onto themselves. Okay, why do we stop OGTT at 34 weeks? Because of insulin resistance. Normal pregnancy, insulin resistance will occur in the 3rd trimester. Okay, so the cortisol, the human placental lactogen, and another one I can't remember, growth factor I think, will cause insulin resistance, but it will cause some glycosuria, it will cause some hyperglycemia, but those are not necessarily problematic to the mother or the fetus. So we don't want to label them as GDM because label as GDM means you need to induce early. Okay, you need to monitor blood sugar monitoring so frequent that it will affect the patient punya quality of life and away from the work apa semua. So indication for admission. Okay, kejap. Asking about pre-eclampsia may be complicated with DIC. Okay. Pre-eclampsia, DIC. Pre-eclampsia, dia ada banyak dia punya etiology. I would suggest you read the guideline I shared with you. Some of them has discussed about the etiology as well. I can share with you later another site, e-learning and RCOG. Tapi itu is a membership punya account. It discuss about genetic, discuss about vascular, about the prostacyclin and semua of preeclampsia. A lot of etiology. This is postgraduate punya topic. Okay. So what is most commonly discussed is the failure of second trophoblastic invasion kan, causing the spiral arteriole in the uterus to be vasoconstricted, not properly broken down for less impedance kan, less resistance. So itu yang selalunya orang kata etiology of preeclampsia. However, there's a newer theory about how preeclampsia dia consume platelet and consume clotting factor causing coagulopathy. Okay, uh, there's a new etiology concerning endothelial damage, which I find interesting. Endothelial damage due to the pregnancy punya condition, pre-eclampsia kan. Endothelial damage will explain the edema. Endothelial damage will explain the cerebral edema and organ damage, kidney problem, liver problem. Sebab endothelial is everywhere in your body, isn't it? It's in your blood vessel. So endothelial damage tu causing platelet aggregation, platelet consumption, clotting factors. So that's probably why apa ni that's probably how preeclampsia consume platelet and clotting factors and can cause DIVC juga kalau dia bleeding. What is an indication of admission for this patient? Faris, I'm not sure you're talking about hypertension or diabetes. Kalau diabetes indication apa tu strictly control dia punya diet kan. Bagi dia makanan hospital je, diet suku-suku separuh, less sugar, less salt dalam makanan yang hospital provide. Kita larang dia daripada dapat apa makanan daripada tempat lain kan, visitor.
Doktor, no, I mean maksudnya patient ni if once dia punya glucose dia is fully control, kita terus admit dia ke?
Kalau if we think we need to control strictly, then we admit and adjust dia punya dose of insulin kan. Dan kita restrict dia daripada makan makanan yang you know at home you don't know what they eat, that sort of thing. We want to control the diet strictly juga. We want to monitor the fetus punya well-being by doing scan.
I mean kalau let's say kalau macam ada fetal compromise ke, kalau ada polyhydramnios memang terus admit lah macam tu. That kind of several factors yang
kalau dah ada fetal compromise apa semua, we think about early delivery lah kalau perlu lah, sebab diabetes ni dia ada correlation with sudden stillbirth kan in third trimester. So the longer you wait, the longer you complacent not doing anything, the higher the risk of tiba-tiba je baby meninggal dalam kandungan kan. Kita takut kalau kita tak act in a timely manner, and it could be our fault. Okay, there's a lot of litigation in medical world. ONG has one of the highest litigation kan, baby meninggal, baby shoulder dystocia kan, fetal distress pun kan, CTG tak cantik pun nak saman doktor kan. So ONG has one of the highest litigation. Insurance pun mahal, 30 ke 50 ribu setahun kalau nak buat private. Kalau buat kerja dekat hospital kerajaan apa ke, kerajaan cover. So siapa yang berminat nak buat ONG, you have to think about that as well. Sanggup ke tak? Kan, nak aja tak sesuai dah. Kena mampu dan sanggup. Sanggup datang ke hospital tengah-tengah malam, nak bersalin, patient nak bersalin anytime kan. Okay. What is the cut-off point for when to change metformin to insulin? Okay, basically, metformin is insulin sensitizer. And if the patient are not producing enough insulin, like type 1 diabetes, they need insulin to be given. Type 2 diabetes, we prefer to give metformin first because most of the time type 2 is because of insulin resistant kan, punya pathophysiology. Tapi kadang-kadang type 2 pun boleh ada lack of insulin production apa juga. So kita if you have to be clinical judgment lah juga. You start with metformin, if it doesn't work and you have increased the dose, so you think about insulin level to bring down the blood sugar to ideal level fast juga. So it has to be multidisciplinary approach juga. don't just the obstetrician do it, because the medical, the endocrinologists, they have a lot more expertise in this area. They have a lot more apa tu brand insulin type at their disposal. They can suggest a better suit insulin for the patient, kan ada macam-macam jenis available in the market nowadays. So I think it will be better if we do a multidisciplinary approach for this, and give them the chance to manage the patient as well. For BSP monitoring, how many abnormal reading do we need before we consider changing the treatment? Okay. It's a clinical judgment juga kan. Kita tengok kita punya patient juga, what type of patient. Is she a compliant patient, or is she trying to cheat the system by, you know, BSP je dia control lah, waktu lain tak control. If we suspect that, you can do HbA1c to check compliance issue kan. Kalau high, maknanya highly likely dia tak compliant other time kan. So when we want to change the treatment, we have to look at the patient as a whole, not just the number of the BSP result. So you want to check for any complication, patient compliant, dia punya easy accessible to boleh buat BSP ke, senang ke tak kan. Sebab bila dah start on insulin ni, BSP kena lagi kerap kan. Okay, so treat the patient as a whole, consider all the other factors juga, but make sure the health factor is the priority. 6 weeks postpartum, we still use 5.1, 7.8. Okay. After 6 weeks postpartum, kalau kita pakai 5.1, 7.8, we diagnose as impaired glucose tolerance test. Okay, they have pre-diabetes lah, lebih kurang. That they have high risk of developing actual DM. DM kita pakai 7-11 kan. So kalau yang 5.1, 7.8 ni, they need to control their diet. They're more aware lah that they can get diabetes later on in life kan. Okay, if we change the treatment from metformin to insulin, do we stop the metformin? No, continue the metformin. It will have synergistic effect. Okay, metformin is a insulin sensitizer. It will help with the insulin punya effect. Okay, so I will look at what is the role of folic acid in unplanned pregnancy. Folic acid, the main issue ialah neural tube defect. Okay, folic acid not necessarily from the supplement. You can get folic acid in your food, dietary, what you eat from green leafy vegetable kan. If you eat enough portion of green leafy vegetable per day, then you don't have to worry that much about taking folic acid supplement. But unfortunately, Malaysian population jarang yang makan sayur hijau 2 to 3 times per day. 5 portion of fruits and vegetable per day. You can do a quick survey, 100 students in this room, how many of you take 5 portion of fruit and vegetable? You can do it in your own time. Okay, I don't think a lot of people do that. Okay, so they come out with the folic acid supplement, so that it's easy to take. It's very cheap as well. You can get a 1 month supply of folic acid for 3 ringgit. 3 ringgit, 10 cent per tablet, 10 cent per day is very cheap. I think they should give it for free during apa tu, khusus kahwin. I think so. Okay, cheaper than a plate of rice kan, plate of rice. Sekarang ni makan nasi pun RM5 paling kurang kan selalunya. Nasi budget RM5. Make sure you take your vegetable. Okay, if patient do self monitoring on its own, it will be documented. Yes, you should document the self monitoring blood glucose level in the apa tu, in the chart or semua kan. And every 2 weeks or so you have a visit with your doctor kan. In the US nowadays they have a newer device that do continuous blood sugar monitoring. They it's like a sticker patch on your skin, and it can measure your blood glucose continuously. So people are getting more advanced with the technology and everything. And I'm not sure whether those devices are available in Malaysia yet. I don't think so. But we are trying to control the blood sugar continuously nowadays. Okay. So every 2 weeks BSP is no longer recommended. Actually, it's becoming obsolete. Okay. We're trying to get patient to do self-monitoring blood glucose first. If the technology arrive, we can do continuous, kan. Ada insert wifi sekali, boleh send the result to your doctor straight away, kan. That's the future. That's your future. Your future. Then during intrapartum, does it mean that we can start OHA? Okay, during intrapartum, they usually say you stop your medication because intrapartum period, your intestine, your gastric motility will be reduced. Okay, so it's difficult for you to digest what you eat, and let alone get it to be effective. So during intrapartum, we prefer insulin. Okay. Even insulin bolus pun kita prefer insulin infusion actually if needed. Okay. Metformin in postpartum, yes. Do we practice it? I think we have to ask the KK doctors whether they continue patient with metformin or not. I don't think, at the moment, um, those who are GDM, I think not more than 50% are on metformin. So we are still implementing it step by step. Not everyone on metformin yet, but there's still a lot of GDM on insulin. But you know, IUM Medical Center has a lot less patient compared to KK and HTAA. So I'm not sure how. If you want to quote the CPG, that will be the best, ideal way. Okay. So we should aim to follow the CPG, inshallah. Right, 5 more minutes. Any more question? What is the suggestion treatment period on metformin? I don't understand. How long you want to be on metformin? Is that what you mean? Okay. Can diabetes be cured? That's the question. Can you cure diabetes? Can you control diabetes? Yes. But can you cure diabetes? That's a debatable question, isn't it? Debatable. So if you control diabetes, you control your weight, you control your diet, you control your exercise, inshallah, you will reduce your risk to develop diabetes. Okay, that's all we can say at the moment. Okay, anyone who claim they can cure diabetes, they are overclaim. Okay, overclaim. And if you report to the Ministry of Health, they can be summoned. Okay, that's at the moment. Who knows, during your time when you become endocrinologist, maybe you can invent a cure for diabetes. You know, it will be $1 billion, $1 trillion idea. Shakir, Sharafina, Adin, Faris, you know. Can you touch on DIK regime? Okay, DIK regime is insulin infusion that is usually used during labor. Okay, according to the CPG, you do it if the blood sugar profile is more than 10. Okay, if it's more than 7 to 10, you check again after 1 hour. If it's still high, you start on the DIK regime. Okay, DIK stands for dextrose, insulin, and potassium. Okay, kalium is potassium. So you want to give the patient this infusion with the titration. The titration you can find in the guideline. Okay, it will control the blood sugar strictly within range. Okay, you check hourly with the capillary blood glucose and adjust the dose of the insulin infusion. Inshallah, it is important to control the blood sugar during labor to reduce the risk of fetal distress, to reduce the risk of patient becoming hypo and ketotic. Okay, the ketoacidosis of the mother can cause acidosis of the fetus. Okay, come out flat. Okay, so that's what you want to do. And most of the time, the patient in labor and they don't want to eat, even though they can have a light snack or something, they don't want to eat. They are afraid of going to emergency Caesar or anything. And so they tend to get hypo and ketotic breast. Okay, so you want to avoid that by giving them the IK regime. All right, final question. Any final question? Inshallah. I hope you. Oh, did we record this? I think yeah, it's recording. Yep. So we have 2 recording for this session. One for hypertension, one for diabetes. Inshallah, I will share the recording later to the AJK Urustia. Inshallah. Shall we take picture? You want to take picture? Let's turn on your camera. Take picture. Uh, turn on your camera. Make sure everyone covering their aura. Good. Excellent. Oh, everyone's smiling. Alhamdulillah. Hold on, I haven't prepared my camera yet. Okay, turn it. Change it to full screen. Sekejap, Nice. Okay, everyone smile, make smiley face and love and nice. Okay, next page. How do we get to next page? How do we change next page? Anybody knows how to change to next page? I only have 16 faces in front of me. Kesian siapa next page ni? Banyak ni. Tak ada next page. Alah, kesian. Okay. Oh, excellent. Smile, smile, smile always. Okay, tak apalah. No worries. I used to have the grid, but I already deleted last time. Sorry. No worries. As long as we have all learned something today. Hypertension and diabetes in pregnancy, very common, very important topics that you need to know inside out. Highly likely will appear in your exam, in your work life later on. Okay. All right. Shall we end here? Inshallah. No problem. You're
Thank you
welcome.
very much, Doctor.
You're welcome. I miss you guys
Okay.
as well. All my dayang-dayang and my bodyguard. Jentikan hati kan. I hope you still terjentik hati untuk jadi baik.
Thank you, Dr.
Okay. Thank you very much.
Thank you, Dr.
Inshallah. Keep in touch. Okay. My Facebook, my Instagram, my YouTube channel nowadays.
Thank you, Doctor.
Okay. Okay, kita stop recording dulu. Alright. Signing off. Okay. Assalamualaikum warahmatullahi wabarakatuh. Bye.
Waalaikumsalam.
Selamat, Doctor. Thank you.
Okay.